right, test, 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 test. Hi, good afternoon. This is Dr. Garias, and this is MED285 electrocardiography, and I'm about to go over Chapter 6 in your textbook, Atrial Dysrythmias. So, if you recall, let's look at there was this picture that you guys saw on your exam this morning. And it kind of looked like this. Look familiar? Okay. So, we're measuring the electricity of the heart, and now for the last couple of weeks we now have focused on what was normal. Okay? What's normal? The SA node is our pacemaker. It fires to the AV node. That's the brakes. It slows it down, then sends the signal to the bundle of His, to the left and right bundle branches, and all the way down to the Purkinje fibers. Okay? Now we're going to focus, every week we're going to focus on a new problem, or every lecture. And today, Chapter 6, we're going to focus on the problems that occur here, in this region. So the pacemaker, your SA node or your sinoatrial node, has a problem. Or that area of the heart, because if that area of the heart is diseased, it's going to affect the electricity. So, we're going to look at the differences and how to tell them apart. Okay? Premature atrial complex, wandering atrial pacemaker, multifocal atrial tachycardia, atrial flutter, and atrial fibrillation. Can you identify these things? And I'm going to provide for you guys on Moodle like this blank page of all the pictures. Because remember, studying isn't reading. Did you see? Did I read any of these outcomes? No. I did what? I looked at what was the main thing. So, what do I need to know? I need to know what makes everything the same and what makes everything different through all of these things. PAC, premature atrial complex, WAP, wandering atrial pacemaker, MAT, multifocal atrial tachycardia, and then atrial flutter and atrial fibrillation. And notice flutter and fibrillation sound a lot alike. Guess what? They're going to start looking alike too. But we now know that all the problems are now what? In this particular chapter, atrial. Okay? So, let's look. The main problem with atrial dysrhythmia is called an ectopic impulse. Now we know what impulses are. Action potentials, the electricity. Ectopic, let's look at our medical terminology powers. Ectopic, ec means out. Ic, pertaining to out of tope, or place. So, the SA node, the origin of the action potential is the SA node. But what would happen if the SA node was broken and the electricity was coming from other places? That's not good. So, let's see. Remember, all abnormal is just mess with normal. So, it could be a neurologic problem because it's, or it could be a myocardial infarction in your atria. Okay? So, now it makes sense. So, if you want to know the hardest way to study this chapter, like I've always said, read it. Read the chapter. Look at this. This is crazy. How's this? I'm a visual person, and most people are. Let's look at what? The picture. Okay, so let's look at this picture. Now, when you look at it, this one seems normal. This one seems normal. And let's look at the word, premature. Can't you see that this one came early? It's kind of got smushed over. So there was like 1, 2, 3, like 4.5. 4.5 big boxes between this R wave and that R wave. When did the pack come? It came in what? In 3 boxes. That's not good. So now you can see how it's like bunched up. Now how do you know this is a pack? Because everything looks normal. It's just that what? It happened earlier. So that was called a premature atrial complex. And another thing you're going to also see is what? You see the P wave, how small it was here? The P wave is small here, P wave is small here. Look at this P wave. Does that look normal to you? Right? Typically a P wave is what? 0.1 millivolts high. This thing's almost 0.3 or 3 small boxes. Something's up. So that's how you, so if everything looks normal, except for that P wave looks really high and it happened really too early, then we know this is a PAC. And by the way, I will only use the traces from your book. I'm not going to get traces from other places. So look at the pictures in your book. So all it is what? Happened too soon. And now we know why. Ectopic impulse. It's coming from, it's supposed to be coming from the SA node, but now it's coming from someplace else. And it's coming in way too early. Okay? Now don't worry about how the patient's going to be affected and whatnot. What is our focus? Our focus is, can we identify the traces? So between A and B, this could be a nice question, right? And can you copy and paste this onto a piece of paper and then ask yourself, which one is the PAC? The one on the top or the one on the bottom? The one on the top. Because how do I know? Is there a PQRST on every wave? Yes. Are the R to R waves even? No. So if they're not even, let me look at the P wave of the one that came in too early. Is it a little high? Yeah. Look, it's like 2.5 little boxes. Now, what was this called? Remember last week? This was called what? No. It's not asystole. Asystole would be what? The whole 6 seconds. Flat. And remember, the book and also my exams will only show 6 seconds at a time. So if you see that, that's not 6 seconds. So that is what? That's a pause. Right? That's correct. That was a sinus pause. So B is a sinus pause. A is what? Is your PAC. Premature atrial complex. Because it happened what? Prematurely. Happened too soon. So I could do that. Can I do that on an exam? Like show you the picture and kindly say, identify. Is this tachycardia? Is this bradycardia? Is this PAC? Or is this a systolic pause for the one on the top? How about the one on the bottom? Could I do the same exact thing? Yep. And welcome to your final. This is exactly what your final is going to look like. Because you need to identify that so you can, just imagine if you told the doctor early, oh, it's a PAC. Then I have a whole bunch of things in my head that are now what? I'm now not thinking about the ventricles. I'm now not thinking about the bundle of His. I'm now not thinking of the Purkinje fibers. The only thing I'm thinking of, the second you say PAC to me is what? Oh, he's got an atrial problem. SA node. Right? That's the $14 an hour MA, not the minimum wage MA, not the MA that got their certificate in a Cracker Jack box. That's the professional who's going to move on. And I can tell you right now, even nurses and most techs can't tell me. So, let's go to wandering atrial pacemaker. Okay, wandering pacemaker. Where's your pacemaker supposed to be? SA node. Now, it's not going to go anywhere. It's not going in the right place. So let's look at what a wandering atrial pacemaker is. And here's a little, here's the difference. The wandering atrial pacemaker, the rate is usually normal. Okay? Now you notice that each one of these things, I like the way the textbook goes. It not only goes by what part of the heart gets messed up, it goes by the least problems, like the PAC, and then to atrial fibrillation, which is horrible. So it's going to go, like every wave that you learn, it gets worse. So let's look at this one. This is WAP, or wandering atrial pacemaker. So, just like before, it looks normal. But now, what do we see? The rhythm is slightly irregular. What's so slightly irregular about it? Everything is normal except for what? two things. Rhythm is irregular, and the P wave gets messed up. Let's look at all the P waves. Do you see how it's here? And it's what? 4 or 5 little boxes away from the R? Then it's here. Now it's 2 boxes. Then it's here, right? And it's even flat. It's flat. And now back to 3 boxes. Then it's here. Then it's almost inverted. So I show you this picture. It looks normal, but let's look at all the P waves. And I'll even give you a hint on exams. I'll even tell you this is abnormal. And then you must tell me what? What's abnormal? So, what's the abnormalcy in WAP? It's only slightly irregular. It's not like the PAC. The PAC, you see it was regular. You definitely know. Right? The rate looks normal, 60 to 100. But what do we notice about the P waves? So that's one question I could ask you in WAP. What's the big problem in WAP? Well, it's the P waves. They're all different, and therefore the PR interval, or the timing between the P and the R wave, is going to be all different. So that's a wandering atrial pacemaker. And why? Because the WAP, right, is not coming from the SA node. The signal is not coming from the SA node. The SA node is damaged, so the signal is coming from other parts of that atrial wall, and it's going to form these problems. So let's look at between these two, right? Which one of these two looks more normal to you? A or B?
A.
A looks more normal, right? But we definitely know that A isn't normal because, do you see that last part?
Yeah.
It's slightly irregular. And I'm looking at this is what, 4 boxes. This is like 4 boxes, 4 boxes, a little less than 4 boxes, 4 boxes, and then it gets what? 1, 2, 3, 4, 5, 5.5 big boxes. This one, let's look at this. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Hey, the one on the bottom looks what? Regular. So the one on the bottom looks good. Now, let's look at both of them. Did they all have a PQRST? Yeah. But let's look at the one on the top. Let's look at the PR intervals. Look at this P wave. It's what? 3 or 4 boxes. This P wave, 3 or 4 boxes. Little boxes. 1, 2, 3, 4. Right? The space in between here and here. It looks pretty even, doesn't it? Even though it disappears a little bit here.
Yep.
And let's look at this one on the top. Look at the P wave. It's 3 boxes. This one's 3 boxes. Oh no, this one's more, but this one's more regular too. Let me look at these. This P wave, but whoa. No P wave. No P wave. And now, it's not 4 boxes, this is now what? 4, almost 5. So now, we're looking at criteria. A minute ago, we liked A. But we looked at the P wave in A, and the P wave in A looks what? Normal. But the P wave in B is what? Definitely abnormal. And look, you see, on this one all went upside down. This one's higher than normal. And what is the theme for this chapter? Atrial. Which wave is atrial depolarization? So the correct answer for this checkpoint question is B is the wandering atrial pacemaker. And A is simply what? Just an abnormal rhythm. That's a nice question. It's hard, but nice. Now, the first two we talked about, the PAC and the MAT, PAC and the WAP, there was normal rates, right? 60 to 100. Now, if you look at MAT, you now know that it's going to be tachycardia. So, what's the theme here? P wave is going to be a problem. Now, it's not only going to be a problem, it's now going to be fast. So let's look at this. Whoa. Look at that craziness. It looks like almost no two P waves look alike, don't they? They all look different, don't they? And now, we know it's tachycardia. How? Just by looking at how many spikes there are in a 6 second. So let's do our 6 second rule. 1 complex, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. 14 times 10, 140 beats per minute. Is that normal? Nope. Okay. So if that's abnormal, I know the P wave is messed up. I'm looking right at the craziest P wave I've ever seen. Looks nothing like NSR. So now I know it's what? It's got to be multifocal atrial tachycardia. Because the P wave's messed up and it's fast. All right, let's look at the next one. Which one is MAT? The top or the bottom?
The bar.
The bottom. Because on the top one, you can't even see any P waves. The top makes no sense to me yet. We're going to talk about that trace in a minute. That's atrial fibrillation, the one that's on the top. But we definitely, they're both tachycardic, but now you see that the one on the bottom, letter B, the trace B, you guys can see that? I hope you can see it. Let me see. The trace here on the bottom here, trace B, page 153 on your textbook, you see that all the waves are there, the P waves are messed up, and it's fast. If you look at the top, are all the waves there? I see a QRS, but what happened to the P and the T? This is craziness. And we're going to talk about that one in a moment. So, do you see what the book is doing for you? They do a little section, and then they do what? Testing on it. A little section and testing on it. Do you think you could simulate that at home? Yeah. Do that. Instead of doing what most students do. Let me read the whole entire chapter and then be depressed because you didn't remember anything. Nothing went in my head, Dr. Grimes. Of course it didn't go in the head. Didn't go in mine when I did it. You know what I did when I learned EKG? I just memorized all the traces. I just oh, that's what that looks like. So what did I do? I messed up all over the place. I remember, I think I had a C- grade for electrocardiography in that section of the cardiac internal medicine section of medical school. I got a C-. Why? Because all I'm doing is memorizing. This now breaks it down and makes you understand. So now you know. P wave. P wave means atrial. These are atrial problems. Therefore, the only problem you'll see is P wave. Atrial flutter. Okay. This is when your atrium starts to break down. And if you look at it, doesn't the little P waves look like it's like swimming? Like flutter kicks? You know when you kick in the swimming pool? Doesn't that look like a swimming pool when you kick? Your P wave is fighting to stay normal. Look at that craziness. That's not good. Okay? It's trying to stay regular. And the atrial rate would be just crazy. Look how crazy it is. Now, atrial flutter. Can you tell the difference? Which one's atrial flutter? A or B? A. Because it looks like what? The atrium is trying its darndest to keep afloat. Now, what happens when it can't do it anymore, when it starts messing up? You get this thing called atrial fibrillation. You see that there's no more P wave? Everything is nuts. Fibrillation is an emergency trace. If you see AFib and the patient has no history of AFib, because there are some people who have a history of it, and then they take medication, so to them this might be normal. I mean, it's not a normal situation, but you could see that. So if you see on the chart that the patient has a history of AFib or atrial fibrillation, and you can see how chaotic it is. And look at the R to R intervals. If the P wave isn't working right, remember, it's right connected. It's right on top of and right next to the ventricles. Do you think the ventricles are going to be able to fill up correctly? No, so it's going to struggle. So you can see how there's a progression of problems. We started off with what? It kind of looked normal, didn't it? Right? The PAC, everything was normal. All the waves were there. And then the MAT, the WAP, okay, it's a little bit worse. The MAT, okay, now it's getting bad. Then the atrial fibrillation, the atrial flutter, okay, that's not good. Now the atrial fibrillation. So you can see there's a progression from not so good to what? Horrific. And the atrial fibrillation is an emergency trace. You know your emergency traces. That means you do what? Stop the machine, inform your chain of command immediately. This person will be symptomatic. This person, because we'll have some trouble breathing, we'll have some we'll have chest pain. There's going to be a whole bunch of problems. Because remember, just because you're the technician, pay attention to your patient. Remember I told you I always get in trouble at Nova? Got in trouble again this week. Brought my wife there, they had an ultrasound, and the technician can't tell me anything. And all she's trying to do is use a lot of technical jargon, and then I'm like... And then she got really defensive when she found out I used to be a former dean of an ultrasound school. So I'm not... So I know stuff, but I was hoping she'd help me know stuff. I really can't stand that place. I really shouldn't bring my family there anymore. But hey, so if you have AFib, you could be experiencing a heart attack or a CVA. So remember, CVA, cerebrovascular accident, that's a stroke. Myocardial infarction, MI, that's a heart attack. They could be going through some pulmonary embolism. That means like a blood clot from your lungs is now traveled into your heart, and now you are in very big trouble. Renal infarction, meaning what? There's a blockage where? In your kidneys, which will backflow into your heart, and then we got a whole bunch of problems. So these things, AFib is very dangerous, okay? Because it can form blood clots really easy. And it's not pumping coordinated with your ventricle, so eventually you're going to get sick. Alrighty. Which one is the flutter? A or B? Flutter. What's flutter? Is not the... Fibrillation is the worst. Flutter is next to worst. So which looks next to worse? A. A looks bad, but at least it's kind of organized. So that's got to be flutter. Think what? Little waves in a pool. That's what it looks like. Now, B is fibrillation. Because why? There's nothing even remotely coordinated about what's going on here on your baseline. Well, good news, if there isn't any good news here, the QRS is still good, but the P wave is so messed up that it even obscured the T wave. So that's how you know that's atrial fibrillation, also known as AFib. And the other one on top, trace A, is atrial flutter. So that's flutter versus fibrillation. And they sound alike, don't they? Could that be one trace and the other one be the other trace? And remember, these are so easy to create on your own. Watch. I'll show you how fast. Control, print screen. Then I open up Microsoft Paint. Then I paste. Okay, I add that. Take this, take this. And then crop it. Then maybe put letter A here. This is letter A. And this, of course, is letter B. Let me take this B. Hey, doesn't that look like a nice exam? Mm-hmm. Which, by the way, hint, hint, that's your quiz next week. Which of the following is an atrial problem? Letter A, letter B, both, or neither? Both.
Both.
He goes, what wave is affected in letter A? P wave.
P wave.
What wave is affected in letter B? P wave. All right. Which one is atrial flutter? Letter A or B? Flutter.
Oh, letter E.
All right. Which one is outright fibrillation? Outright trouble?
B.
B. Which one is an emergency trace? A or B?
B.
B. All right. What should you do in B? Stand there, complete the trace, or call your chain of command immediately. Call your chain of command immediately. Call the doctor immediately. Because if the patient has no history of it,
Bring the certificate.
that's trouble. Even if they did have a history of it. Say, yes, doctor, the patient is having AFib right now. And they have medications to, because maybe the patient didn't take their medication. Right? So, you saw in less than 20 seconds how easily I created an exam. So what can you do at home? That's what you do when you're studying for this. Don't read this chapter. Forget reading this chapter. Do what? Just take all the pictures, copy and paste them, put A, B, C, D, E, have on the back of the paper the meaning, and then do what? Quiz yourself. And you could do this, and think about it. How many times did you watch Netflix? I watched Netflix last night for like 3 hours. I could have been doing what? Studying. I could be doing other things that were productive instead of watching movies and being silly. I was up till like 1 o'clock watching movies. And then I complain about what? I have no money, I have no this. I should have been doing what? I should have been on Facebook. I should have been on Twitter. I should have been on Instagram. Trying to get some jobs. Trying to get some buzz. This whole entire weekend, I don't have any paying gigs. That means no money coming in. I should be focusing on what? Trying to do something, money coming in. That's why next week, I'm going to hit up every weekend facility and seeing if they need me. Hi, I'm just off the street. I'm going to do a cold call. Oh, we don't appreciate solicitors. No, I'm not a solicitor. I'm just want to see here and want to speak to your chief academic officer and see what I can do for them. And once they need me, once they talk to me. Right? Because it's personal. I can try to call or email or go through a website all day. Networking. Networking is how to be. And I'm going to put something like this on, but it's all in your book. So you could sit here and try to memorize it all. But how about this? On the chapter review, did I go over any of this? No. It's not. But what did I do? So, looking at all these multiple choice questions in the back of chapter 6, okay, yeah, you could do that, but what have you been doing for the last 32 minutes, according to this camera? What have you been doing? Pictures. So I get to the end of my book, end of this chapter, and then I do what? I hit up all these pictures. Here's one. Here's another one. Ooh, look. Look at that. Look at that. And also, you now know what? I get only the traces from your book. So you already know what your final will look like. Now, we're going to add a new wrinkle. Of course, you guys, every week, you guys are going to do and get a trace, from me, and then it comes out, right? You already know how to identify what's normal and what's abnormal. But this is what I'm going to do to you now. Now I'm going to have a piece of paper and say, this came out. What is the diagnosis? And that will be part and parcel of your weekly quizzes, of your weekly practicals. Because remember, I'm trying to simulate real life as much as I possibly can. Because if your patient is AFib, is another AFib, okay, this one, it's not fast, so it can't be MAT, so I look at the P waves, that one looks normal, that one looks normal, oh, this one looks crazy, that one looks crazy, this one's missing, This one's so far away from. Look how far away it is, versus how much closer it is here. Here's about 3 little boxes. Here's about what? 1, 2, 3, almost 4. So the PR interval is all screwed up. So right off the bat, that can't be it can't be MAT. What's it got to be? It's got to be what? Right? It's got to be a wandering atrial pacemaker. Has to be. Now it goes, but could it be a PAC? No, because look at the R to R intervals. They're really regular. So that's not a PAC. But I look at the P waves. They're all different. They're all weird, and one of them's missing, and one of them's upside down. So that's got to be a what? WAP, wandering atrial pacemaker. Now, so that's what you do. You take all of these, copy and paste them, and then do what? Practice. Do it. How's this? I challenge everybody who watches this video. 15 minutes a day. That's it. Don't study any longer than that. Just 15 minutes looking at that same 5 traces. 3 minutes per trace. And then mix and match them. And you should be able to ace this quiz next week. Because what's the quiz? I'm just going to ask you questions. And by the way, all those questions that I went through, right? It's the same thing. It's the same thing. And is it, lo and behold, is it any surprise that you're going to see some of these questions on my final? Yeah. All right, that concludes chapter 6. Next week is chapter 7, the junctional. So what's the junctional? That's like the next step, which is, the junction between the AV node and the bundle of His. So there's still going to be atrial problems, but now the atrial problem's going into what? Ventricular. So it'll be P wave that's messing with what? The QRS. Okay. So but right now, for this week, the only thing you're going to be thinking about is those 5 traces and it's P wave. All right. Thank you for watching this video. Please hit subscribe.
Not live without any. You need at least 1 kidney. But living without one is not, you'll still function with just 1 kidney. So that's why they sell kidneys. UNOS, have you heard of that? UNOS, United Network Organ Sharing. This is the organization regulates allocated organs in the Okay. So there's at least more than 106,000 people listed on this waiting list. Okay. So they are responsible for allocating these organs for transplant. And how do they decide? They base it on medical need and the other half to considerations of justice. Meaning, is it fair that this person gets an organ? Do the medical needs benefit more for that individual? So it goes through a process. They don't just decide, okay, you're first on the list, you get the organ first. Okay, so it goes through an investigation, it goes through your case. Are they able to survive? What is the best way to give the organ? Transplant rationing. Okay, so how are we going to decide is donation model organ are taken with consent of the donor? Okay, so the uniform anatomical if that service is competent to allow permitted use of their organs after that. So that's part of the uniform. Okay, so if anyone here a donor?
Only thing I will be able to donate is my skin.
So you're listed as you don't be a donor. Anyone else?
I changed my mind, but because I thought about it, yeah, they don't.
Which did you use? You use skin. Other popular organs that are donated are the eyes, the heart, all the major organs. Liver is another one.
And then there's 2. Yeah, I can't even use blood, so.
Blood is another donation. Donor blood is common that happening now over like American Red Cross. Has anyone here donated blood? Do they keep calling you? They're always calling. I donate blood as well, and they're always calling. It's always a need. So how do we ration these? There's a social utility method of allocation, which is more common. So they will screen and match the donor, okay, and see what their survival is, and they will evaluate, and then they give these to the patients who will benefit the most. Okay, and then we have justice, which gives everyone an equal chance. So which one is better?
What happened?
Yeah, between these two. Do we give everyone an equal chance, or do we need to go through this method of allocating? Okay, so they usually go through this screening process, go through their case, and then they will decide on a first come first served basis. Okay, so they go through this screening process first. Whoever's on the list, then they will give the organ to. Does everyone agree with that? Your grandmother